So we're talking about the Pentacam and Corvis screening for patients prior to refractive surgery. I love being able to help and answer questions. And of course, if you have questions throughout, just feel free to jump in and ask questions throughout. So I'm practicing in Miami, Florida, the Center for Excellence in Eye Care. I've had a chance to work with Oculus for 15 plus years, maybe closer to 20 years. So it's been really wonderful overall. And so when we're looking at patients with who are interested in refractive surgery, we want to figure out who's a good candidate and who's not a good candidate. And I definitely rely on Oculus and Pentacam and the technology that they've developed throughout to really make sure that my patients are the right candidates. And I want to know if they have an increased risk for developing post-LASIK ectasia. And so we're going to use the screening tools to identify those patients and also figure out who's the best candidate. Also, we're looking for the level of astigmatism. Do they qualify for LASIK, SMILE, or PRK? So as you know, there's different types of technology you can use to evaluate the corneal shape. There's placido disc topography on our left, and then tomography, the shine fluid camera. And placido disc was popular many years ago and still being used, but shine fluid is certainly taking the, is really where we're at now with really advanced diagnostics for evaluating patients. So here's an example of one of my patients with a, you can see a Pentacam, and this is how they looked with a placido disc. So if we have a patient who's keratoconus and we're going to follow them over time, we really can't follow them over time with a placido disc. They just will not know if they're getting better or worse. So if you have a practice where you see patients and follow patients with keratoconus, placido disc just doesn't really help us enough. And that's why you need to use a shine fluid technology such as the Pentacam. These are patients that have some type of corneal irregularity. As you're probably familiar, the first one is keratoconus. And the second one we call pellucid pattern keratoconus. It almost looks like pellucid. And then our third case is actual pellucid marginal degeneration. So we have three different types of patterns that we're looking for. These are more advanced, but we're also use this technology to screen for our patients with less advanced conditions. How common is keratoconus? This one study from the Netherlands suggested that it's about, out of 4.4 million patients, that's about 1 out of 375 patients. I think they're missing a lot of patients still in the study. I think it's much more common than that. The mean age of diagnosis in this group of patients, mean age is 28 years old. So again, they're not, we think of this is keratoconus as a condition of younger kids, but actually I've diagnosed plenty of patients in their 40s and 50s and 60s who had no idea they had keratoconus. And you can see 60% of patients were male, which is also more common. It's usually 60% male, 40% female. In different parts of the world, the prevalence goes up. So, when patients that are in the Mediterranean that have a lot of sun exposure, it's higher percent, such as Israel, Saudi Arabia, places like that have much higher rates. And again, Netherlands and other places have a little bit lower rates. But again, I always wonder how the studies are done, and we still need more data on these percentages. Now, one thing I'm interested in doing is looking at my patients coming in for cataract surgery. And so this is a study that we did many years ago, not using the Pentacam. And we found that 24% of the patients had some type of abnormality prior to cataract surgery. Some had previous LASIK, some had irregular astigmatism from dry eye, but 24% had some type of irregularity overall. And you can see here we found keratoconus is about 3%. So in the United States, 3% would be a high number. 3 out of 100 patients. We don't typically think of it as being that common, but it may be in our patient undergoing cataract surgery. Right now, I have a couple of medical students that have helped me. We've gathered 1,000 consecutive patients, 500 consecutive patients, 1,000 eyes that have undergone cataract surgery at our clinic, and we had the Pentacams for each of those. I'm grading them. I actually have graded 550 so far, but looking at the K-max, we had 45 of the 1,000 eyes, or 4.5%, that had a K-max of 48.5 or higher. Now, some of those might have been previous hyperopic LASIK, but some may have EBMD that's got a higher K-max, but we'll see. I'm grading them now, and I expect it could even be higher than 3%, could be 3.5 or 4% of our patients coming in for cataract surgery may have keratoconus. So it is more common than we realize. And so, jump here. So the other thing is that keratoconus is often discovered late. For those of you in practice, patients come in their 30s, 40s, and 50s, they don't realize they have keratoconus. And so the question here is, what do you think their vision is? These are 4 Pentacams of patients. What is their uncorrected vision of these 4 patients? 20/50, 20/80, 20/100. Any guesses? I mean, what do you think? What do you think they saw? 2050? Because they look pretty, especially this one looks pretty bad, right? But no joke. This is their vision, uncorrected. And I checked them multiple times. So many of these had their fellow eye had a little bit more advanced keratoconus, so that's how I picked them up for this eye. But they were able to drive the car and do everything normally because they thought 2020. It's pretty impressive. And I diagnose patients all the time. Again, I had a patient of mine, so I shouldn't say one of my friends. So I played flag football with one of my friends. Now I play fantasy football. So I talked to him a lot. He saw my wife 6 years previously, normal eye exam at age 36. He came to see me at age 42 for a pterygium in one eye. So I did some Pentacam, and he actually keratoconus his other eye at age 42. No idea he had it. And then he underwent cross-linking, but it's just out there. We're just not diagnosing patients as we should. Now, another thing that happens is some patients come in, they look like this, and this doesn't look that abnormal. See this little yellow, a little inferior steepening, but patients can, as you watch over time, they can develop some worsening of their condition. And now this patient has, you could say, has keratoconus. Now this has gotten worse. And what I love in the software that's so powerful is the Pentacam difference maps. So this is what I do for all my patients, whether they're coming in, and I've seen them once, I'm just seeing if they're getting worse, or if they've had cross-linking, I want to see if they get better. But this difference map will show you that the steep part typically gets steeper and the flat part gets flatter. And it's really helpful overall. Now, one thing that comes up is, if we have a patient who had previous LASIK or previous PRK, RK, did that cause them to develop ectasia? Was that the cause, or would they have developed it anyway? Right? People have asked that, they've had LASIK and then now they have keratoconus. So here's a patient, he had 20/80 uncorrected visual acuity and he had this prescription. And so the doctor decided to do 8Ks with a diamond blade in just the one eye that was 20/80. So only one eye had surgery. So let's flash it. He was at this age. So here's the 8Ks performed in March of 2000, 21 years old. And this patient does not have keratoconus at this age. And again, this is just a regular topography. So, okay. And so now the patient, again, let's see if we can go here. And this is how the patient looks now in 2019. This patient developed keratoconus. Was it because of the AK? Who thinks it was the AK that caused this patient to get keratoconus? One person? So I think it was the surgery that caused it, do you think? Well, the good news, we have the other eye. So if the other eye is normal, yes, we can blame the surgery. Let's see. And so there's a pellucid pattern, 19 years previously. Here's the other eye. Uh-oh, it has keratoconus too. So just because a patient has LASIK and develops keratoconus, whereas PRK and develops keratoconus, doesn't mean that the surgery actually caused the disease. And we'll have to see with new technologies that OCULUS is bringing out, the corneal OCT Pentacam. I hope I get the name proper. We'll be able to maybe look a little more detailed in some of these corneas that have had previous LASIK that are developing keratoconus and see if we can learn more things on understanding what's happening with them over time. Okay, so we're evaluating corneas prior to refractive surgery. We do topography, we can do tomography, and we can also do corneal strength measurements. It is an older slide of mine because I remember another company was developing something, but the Corvis is what we're going to talk about a little bit more today. It's really exciting technology that really looks at the strength of the cornea, and we're really excited for it to become eventually available in the United States. It's available internationally. Things that I look at in the Pentacam in our patients, really this box is looking at the normal front surface. You look at the K1 and K2 and the amount of astigmatism, which is right here. So especially prior to cataract surgery is when I'm looking at some of these parameters. And here we're looking at, for our patients with keratoconus, you're looking at the thickness of the cornea in different areas, and also my favorite number, the Kmax. And that's what I use a lot to evaluate patients who have keratoconus or may be at risk, and I follow the Kmax value very closely. And then again, we can look at the different areas of thinness, and we can follow that. But I see that number fluctuates in patients with keratoconus. It's not, patients sometimes will get a little thicker or thinner over time, but that doesn't tell me if they're getting worse or better. But Kmax, I think, is a little bit better for figuring out if they're progressing or improving. And this is parameters for ICL. So anyone do ICL? I love the ICL, and I do use the Pentacam for screening, and we're looking for the AC depth. It can be set at external, then you have to subtract That means it includes the cornea, so you have to subtract the corneal thickness, whatever it is, to get the actual internal, or you can actually set that to internal and it gives it to you automatically. So just a setting on your Pentacam. And sometimes I set it for external, then it gets switched back and forth. So I'm not sure who plays with it in my office. I love what this is, the percentage thickness increase. I tell my patients kind of like if you go to a pizza parlor and they have a pizza dough and the person's spinning the pizza around and putting their fist through the middle part's thinning, but the rest of the pizza dough is the same thickness. That's what happened in keratoconus. And so we'll see this curve where it gets just thinner more rapidly when we go from the outer part of the center to the periphery. It's too thin in the middle versus the peripheral thickness. And so I just love PTI when I analyze patients. And there's the low end of normal and high end of normal there. So if it goes under, it tells you that it's likely keratoconus, and it really helps overall evaluating patients. Now, and it's about 40% thicker from center to periphery. And this is where it's located in this map right here. You can see in this patient, we're looking at this map here to look at the PTI. And also the bad score, of course, which comes on this as well. I don't look at this as much. I'm not sure if some of you are fans of this side of the screening process. It is helpful as well, but I tend to really focus on the right side of the maps. The question is, true or false, the bad score in PTI are only accurate for virgin eyes. The answer is true. It was really set up for patients that had no previous LASIK or PRK or RK, so I don't ever run it on patients that had previous LASIK because it'll come out abnormal. And I'm going to do a lot of medical legal defense, and I have to defend in front of depositions, and I've had to even go to trial and tell the jury why to ignore this done after LASIK. Because I had a patient that they did LASIK and they needed a second procedure, and they did a second LASIK procedure, and the patient got ectasia. And they said, oh, we should have seen it was abnormal. But I'm like, I say no, and it shouldn't, if it was out of the chart, it would have been a little bit easier. We won twice. We won the first time. It was a Delaware case. Something happened, they had to go back again. We won the second time. But just don't run this if you already have, if you've done previous LASIK, PRK, or things like that. There's also the scale is important. Looks, you may not see this, but it looks pretty normal, all green. We gotta look at the numbers. And if we change the scale, look here, see it's 44 to 47. So if you don't have the right scale, you can easily miss, even though it's a 0.5 scale, that this is keratoconus. And we're on the same scale with a different, same map with a different scale. It's much more easier to pick up that this is abnormal. So the scale is really important. We did this analysis with Renato Ambrosio looking, and we got mass. So 10 investigators. We had to grade all the topographies or pentacams, and it was difficult to grade. And we had a whole different rating. So there's 10 people across. You see 3 people said this was keratoconus. A couple people said it was borderline, and you had people that said it was normal. These are Michael Boleyn, Stephen Kleiss, myself, and Renato. And you can see it's because the scale is difficult to tell with this one. And so, let's go to the next slide. But you see, if you change the scale, now this looks pretty abnormal. So it's a 0.5 scale, so it's easier to pick up. So the scale is really important. And so now with this, it's easier to identify. Yeah, obviously, with different scoring systems for keratoconus. This is the old news with IS. I haven't used that. I don't see any topographies really carrying that at this point anymore. And it's for historical reasons only. And the way to calculate it is you have to really go in and manually calculate it, but no one really calculates that anymore. There's other better parameters. What I find is best is really the bad score. It really is very helpful overall. And so here's a patient with a bad score, Pentacam, in both eyes. You can see the right was abnormal. The left one is 2.54, which is that borderline level. But this is the right and left eye of the same patient overall. And so when I have suspects, keratoconus suspect is a patient that, has, family history, maybe it's their age, you're ruling out contact lens warpage. But I do find that tomography can be really helpful, and maybe epithelial thickness maps can also be helpful. So you guys, are you developing anything that's going to have epithelial thickness maps? Oh, yes. So that's pretty exciting. These are some older epithelial thickness map data, but there's a patient that looks like maybe early keratoconus, a little suspicious, but they want LASIK. And so you can look at the epithelial thickness maps, and in normal eyes, you might see a little bit of thickening, but in keratoconus, it's going to be thinning. And so in this particular patient, their epithelium shows thickening. So this wasn't keratoconus, this was just epithelial hyperplasia. And this is Ralph Chu. They did 2 different systems, and they both showed this is thicker epithelium. So this patient could have LASIK overall. And then one of the technology I think is really great, game changing is the Corvis. Corvis is using an air puff technology where it hits the cornea, and in patients with normal corneal strength, the cornea is stiff, but you have keratoconus that's very floppy and wavy, and they use high-speed photography to look at all that waviness and can tell if a patient is a strong cornea or a weak cornea. And this technology is really helpful for screening patients for possible LASIK, understanding their level of keratoconus if they have it or not. And so, again, this is what it looks like. And then, again, they can separate out normal versus abnormal, looking at this corneal biomechanical index. So this patient, which is kind of borderline looking, 2.5 bad score, but has a abnormal corneal biomechanical index on the Corvis. So yes, this patient should not have even PRK, in my opinion, because even though they have, and the thing is, this eye, you had 2 eyes, one was bad, but sometimes this could be the worst eye, the other eye is better. So we're using this to understand what happens, so how to screen patients that don't have one bad keratoconus eye overall. And so, again, this is how the Corvis looks in the bad eye, and the eye that was borderline, the Corvis is still abnormal. So again, no LASIK, no PRK, just watch this patient, probably they need cross-linking. It would be very helpful here. Here's another case. Again, this can show, again, just and separate out these groups. So here's a patient where you can see the Pentacam is not that abnormal. The bad score is in the yellow, 1.83, and this is scoring 0.87, so abnormal. So this is telling us that this patient is at risk, even though the topography looks pretty good. And, the steepness doesn't look that steep. It's 43 over there, 44. The bad scores are alerting us, hey, this isn't quite normal. And then you see the Corvis confirming that this is something irregular. The fellow eye actually has keratoconus, so it was properly picked up that this was, the other eye was abnormal and should not have LASIK or PRK. But again, we're trying to figure these things out in, when they don't have keratoconus in their other eye. Here's a 32-year-old male interested in refractive surgery in the green, but a little inferior steepening. What about this? The PTI is normal. Let's do the Corvis overall. Again, bad score is normal. PTI and the Corvis shows is in green. So I feel good. Even though it's a little inferior steepening, it's probably epithelial hyperplasia. If you do the epithelial thickness map, you should show there's epithelial thickness is the cause of this inferior steepening, not keratoconus. Based on the Corvis and based on the PTI and based on the bad score. So, and again, OCULUS is coming out with their new OCT that will let us have epithelial thickness maps for this case and make it even more clear that this patient could have LASIK or PRK. So in summary, I hope this is a good overview of what OCULUS is bringing to the table for us screening patients for refractive surgery. It's a very exciting time for us as surgeons. The more information we have, the better decisions we can make and really make sure our patients do really well with refractive surgery.